Millions of patients walk out of their primary care visit every day without ever filling their prescription. And for those in the most need of healthcare, that can be life or death. The reason? Patients are forced to make difficult decisions between managing their health, paying rent, or putting food on the table. Part of the solution to ease that choice has been hiding in plain sight for decades. The 340B Drug Pricing Program is a federal program that allows qualifying healthcare providers to purchase medications at significantly reduced costs. But too many patients still struggle with finding time to pick up medications outside of their appointment. Today's guest, RxFusion, is changing that. They help physicians dispense medications right at the point of care, getting life-saving treatments into patients' hands immediately, and unlocking a powerful new revenue stream. This leads to better health outcomes for patients and improved quality of care at your health center or practice. Thank you for joining me today, and welcome to What the Heck? Health Education and Conversations, a podcast by the Oregon Primary Care Association. From healthcare delivery to workforce challenges, each episode features conversations with primary care leaders and partners working to strengthen Oregon's healthcare safety net, as well as expand access for all Oregonians across our state. I'm your host, Dani Gehrke, and I'm curious, what the heck is going on in community health? I'm sitting down with the co-founder and president of RxFusion, and we're going to learn more about his personal experience as a pharmacist and why he established RxFusion. So Josh, can you share a little bit about yourself?
Sure. Yeah. Josh Free, been in Oregon for 15 years or so, not originally from here, but have been working with a variety of OPCA members over the years, and more recently started a new business, RxFusion, which is focused on physician office dispensing. I've done a bunch of other things in my career prior to that. My other company, Nelco Advisory, does consulting and 340B audit compliance. I've worked for health systems. I've worked for independent pharmacies. I've worked for chain pharmacies. So I've kind of done a few different things in the pharmacy realm over the years.
I always love asking this question because I'm also originally not from Oregon. Whereabouts are you from?
I grew up in central Iowa and loved living there and growing up there. My whole family's there, and I'm very proud of having gone to the University of Iowa, landed in Colorado for about 7 years, and then came to Oregon.
What inspired you to pursue pharmacy?
You know, growing up, I played a lot of sports, and I remember one of my coaches was in pharmacy school at the time, and I always thought it was really cool. And I was always into science, and my mom was in healthcare, and so I wanted to be in healthcare of some kind. And pharmacy just sort of was presented to me in that way. And it helped too that, we were very Midwest practical people, and pharmacy, if you pursue a pharmacy education, particularly at that time, you get a degree and here's exactly what you will do with it. And you already know like the couple places that you might work or whatever. It is like, oh, well, that makes a lot of sense. But coming through pharmacy school, I was in a very, very clinical program. And my final year rotations, we call them in pharmacy school, I did very clinical things specifically because I thought I just would never really get to do them again. I was going to go straight into chain retail and had an opportunity to go basically right into a management role and learned other things about that business. Eventually ended up in more of a district regional leadership sort of role, doing all kinds of strategy things and all kinds of things that had nothing to do with pharmacy. And I liked that. And I thought that was fun and interesting and unique. And I don't think any of my classmates thought that that was cool. I mean, I was running the stockroom. I was offloading trucks. And I loved it, right? I prided myself on having the cleanest store and great service and teaching people and coaching them, but also working with the pharmacy and taking care of patients when they needed help or needed support in whatever way. But I used to always pride myself on anybody that comes into that environment, whether it's the pharmacy, the front end of the store, they should be experiencing a clean, welcoming environment. We should have great service. We should have smart people that can help you, that engage you, that are taught how to talk to the customer or the patient or both.
It's really interesting how early on in your career you took pride in that, of knowing how important that initial impression is to continue that patient relationship.
I'm proud of that experience. I think it's important.
Can you share more about where you found yourself after you finished pharmacy school?
Yeah, for sure. At some point A community or retail type pharmacist or chain environment, you can get kind of stuck. And I needed to make a transition. And so in order to grow my career, I just got to do something different. This is what actually brought me to Oregon. So I had an opportunity to come be a pharmacy director of a long-term care pharmacy, kind of a bridge between community and maybe more clinical type settings, kind of fits in the middle. Worked for them for 7 years and eventually had the chance then to move into a hospital role, specifically a business role here in Oregon, overseeing regionally all pharmacy business operations, which happened to include 340B. I knew a little bit about at that point, but not much because the entities I had worked for prior, it just didn't touch their worlds at all. And so I take on this role thanks to a good friend of mine who kind of recruited me into that position, which I'm very thankful. And he's like, "Oh, this part's pretty important to us." Oh, okay. Well, I guess I'll learn that. And it was just like drinking out of a fire hose. I think probably for the first 6 months, I'm going through Apexis 340B University and I'm digging in with our TPA and learning about accumulations and all the things that are part of the 340B vernacular. And I think every day for 6 months, I told my friend who was like my peer in this organization, like, you guys are crazy. This does not make sense. Like, it's so complicated. Not that the complexity was what bothered me. It's an interesting way to achieve the goals of the program. But it achieves, I think, a very important goal, which relates to drug costs and inflating drug costs and whether drug manufacturers raising prices or offering better prices to others in the market, like how should that impact the rest of the ecosystem? It is sort of a roundabout way of getting to the point of the program, but I do think it achieves its goal, admittedly in a complicated way.
What are the different ways covered entities deliver 340B eligible medications?
I kind of think of three big categories, and we could go down a lot of rabbit holes on each of these, but I think of drugs administered in a clinical setting. Think about infusions, injections, something that requires a healthcare professional to administer to the patient. I think there are then prescriptions that are filled in a pharmacy type setting. And so if it's the entity's own pharmacy, that's one way of achieving that. Directly dispensing to patients is what RxFusion is focused on. We'll get more into what exactly physician dispensing is and how it's different than pharmacy. But I think those two things include the entity dispensing to their patients. And then we have contract pharmacy, where the entity is writing a prescription to a patient. Patient is taking it out into the community to pharmacy of their choice. And if you've got a contractual relationship between the entity and the pharmacy, then some 340B dollars can be achieved through that relationship. So I think when you look at those three, optimizing all three is important. But then you've got all these other kind of little details about all of those. Contract pharmacy in particular, well, where do your patients go? Where do they go if it's a specialty medication? What if it was a referral situation where you didn't write the prescription, but you did refer the patient to the specialist? So there's all kinds of little wrinkles around contract pharmacy. And then of course, in the contract pharmacy space, you have, I'm sure all the OPCA members are intimately familiar with this right now. We've got drug manufacturers that have added their own rules to contract pharmacy. And so contract pharmacy is not nearly as effective as it used to be because so many drugs are limited. You have to provide data. There's increased administrative burden on contract pharmacy. You lose some money in fees because the pharmacy has to get paid for their service. And then you need management of the data to determine what even qualifies as contract pharmacy. So that comes at a price too. So all those things cause drugs to not qualify at all because the fees can outweigh the benefit, or the patient may just not go to the pharmacy you're contracted with, or the drug manufacturer restricts that drug. And even if you've got one right across the street from you, some number of patients won't even cross the street to get their prescription, right? Some of them just already go to the pharmacy somewhere else. And if that's not the one you picked for your drug manufacturer restriction, then the entity gets nothing out of that transaction. So this is where insourcing your dispensing is so valuable because you deal with no manufacturer restrictions. You put it directly in your patient's hands. Now you're not worried about whether they filled it at all. You'll know because you're the one doing it. Or if there's some strange payer situation, requires a prior authorization, whatever, you might not know about that if they're going outside your walls. But if you can take care of that in-house, you're going to be able to help navigate the patient through that and take care of what's needed to get the medicine in their hands.
Based on the way you explained that, it made me recall one of the key barriers to accessing medication, which is transportation. And that is an issue, especially for those
Yeah.
in rural and frontier areas of Oregon.
Starting with the patient, right? Like what's best for the patient? And if we can get medication to them in a more expeditious manner, and verify that we don't have some hang up that's happening outside our walls, like a prior authorization. I think the patient care aspect, when used the right way, that's the number one most important part. For the clinic themselves, staff tend to spend time trying to figure out what pharmacy to send the prescription to, or the pharmacy calls because they're missing some piece of information, or it's a prior authorization, or all those sorts of things. So these things all take up time to some degree. If you can bring that in house and you're managing it yourself, then that's going to be, I think, a more efficient process, and it's probably touching processes you're spending time on anyway. Well, if we've got someone trained on the dispensing process, and people who deal with prior auths are probably a good person to train on this, actually. Could be, depends on your structure. Then they can just deal with it directly. Less back and forth with some outside party, waiting on hold with the insurance, whatever the case may be. So I think there's some advantages there. Although I do get asked this question, objections to the process, like how much staff time does this take? I would say that it's probably staff time, at least part of which is spent on things you do anyway. But also a really successful office dispense strategy might only be a couple prescriptions a day. Like a good one is probably like 10. And 10 prescriptions a day would be the slowest, most boring pharmacy in the world, right? So one of the goals is that to get started with this, we're using staff we already have. And if you need more staff for it, that means you've got a really successful strategy, because it doesn't take much time to do 2, 3, 4 prescriptions a day, whatever the number is.
I understand. So with office dispensing, you are already working with the staff you have
Right.
at the clinic, at the health center, therefore really enhancing the capacity of the health center to deliver these life-saving medications to Oregonians in our communities.
Yeah. I think the change management aspect deserves attention. Everybody's busy, especially our FQHCs here in Oregon. People don't tend to have extra staff just sitting around waiting for something to do. Everybody's busy. Everybody's working hard. Budgets are tight. So adding something new, even if it's not a huge lift, tends to take a little bit of communication, right? And so I don't want to underestimate that. We're taking staff that already know their job and we're adding something new. And sometimes people don't love that, right? But I think people who are compelled to work for a not-for-profit FQHC or other grantee type organization, if we understand how this ties to mission, the purpose and the patient care aspect of it and the good that you can do through this, I think that really helps.
Is it common to implement office dispensing in primary care settings?
So in most states, Oregon included, physicians, it's just considered part of their scope of practice. And we can lump in the nurse practitioners and physician assistants and others in this general theme as well, that directly dispensing medications to your patients is just considered part of patient care, part of practice of medicine. But traditionally, it's medicine for them to take home and a 30-day supply and refills. Ordinarily, pharmacies are very efficient at dealing with those things, and they do hundreds of them a day and have systems for that. There's nothing saying a physician in the 43 states that allow it can't do that themselves, so long as they follow all of the rules, like it's got to be appropriately labeled. The patient needs to get a consultation, make sure they know how to take it and know how to use it. A lot of the reason why physicians tend to not do this, though, is because the pharmacy benefit, like billing pharmacy benefit, works completely differently than billing the medical benefit. So your physician offices and EHR systems that physicians use are billing claims on a CMS 1500 form, medical benefit claim. These systems don't even have the option to submit a claim to a pharmacy benefit manager for the pharmacy benefit side. But you can, but it just takes a little bit of work to set it up, to get the payer contracts in place, have software that does it, those kind of things. It doesn't seem like such a stretch when you think about the states that allow physician dispensing, which is most states, as I said. And I was like, well, no, physicians should be able to do that if they choose to, so long as they do it safely. They have the records, it's labeled, all those kind of things.
That's helpful to understand what office dispensing is. Now, I'm curious to learn about the benefits of implementing office dispensing in primary care settings, such as a community health center. I would really appreciate if you could illuminate me on how it is beneficial to implement office dispensing.
And so that's what RxFusion is doing, is we are helping physicians to set up the workflow, the safety checks, the labeling, the billing that's needed to do this. And when you can do that, you avoid this problem of the patient might never fill it at all. From a truly 340B economic perspective, comparing office dispense to contract pharmacy, I think that's probably the most relevant comparison. And so if you look at your typical medication that goes through a contract pharmacy, you have to first think about, is it even going to go to a pharmacy that we're contracted with? Is it going to go to any pharmacy at all, let alone one we're contracted with? Is the manufacturer going to allow us to qualify it for 340B? So if you are putting it through the office dispense workflow, there's no TPA involved. There's no contract pharmacy involved. But we do a percentage-based model for using the software and the payer contracts and all the network and everything. But the 340B entity retains more of that savings to put towards the mission.
Now that I have a better understanding of what office dispensing is, can you explain to me exactly what the process is for setting up office dispensing for a covered entity?
For RxFusion, as we are talking to entities about what this program is and what it looks like, I think people tend to ask about inventory. They ask about the scope, like what should we dispense? And then like just the workflow, like the patients in the exam room, do we bring them medication there or do they go up to the waiting room? People have questions about that. And I think the other one I would add is the implementation. Like what's the process to stand it up? Like how much work is involved? Like those kind of things. So let me touch on that one first, actually. We have software that manages the record keeping, labeling, billing. So it's like pharmacy software, but it's a bit more streamlined. So a really effective office dispense program targets just a few drugs that make the most sense for your patients and for your clinic. And so if we're not managing hundreds of things a day with 3 or 4 or 5 people all working on it at the same time, right? You want the software to work a little bit differently. So that feeds into the implementation. That training on how to use that software is pretty straightforward. It takes a little bit of effort, but it's not the same as learning a full pharmacy workflow. But the quality control is built in. There's barcode scanning, there's clinical checks, all those things are still there, just in a more streamlined manner. So we have to get someone trained on how to do it. You have to decide what your workflow is going to be, which is going to be different for every clinic. There's a range of options that you might think about depending on your physical layout and the types of patients we're working with, those kind of things. So we dial that in. And then there's payer contracting. And this is the part that can be a little bit frustrating that we're working with pharmacy benefit managers. These are huge, huge corporations, are not known for being super easy to work with, but we guide getting implemented with all of the pharmacy payers that you need so that you can build these claims out. So all of that kind of goes into the implementation. And I think that's probably one of the first things that the entities tend to ask about is like, what's the process to get stood up?
Let's go back to what you were mentioning before about scope. Can you explain to me exactly what you mean by scope?
I think the mistake for office dispensing is to think that you can dispense everything. I don't think you can. You shouldn't try. We should be narrowly targeting the things that make the most sense. So if you are an organization that is more basic primary care and people are coming in for chronic conditions, then you might think about diabetes. Do we try to carry every diabetes medication? Probably not, but we can look at your prescribing data and see what your most frequently prescribed ones are and the other meds your patients might be taking and have a tailored program around diabetes and maybe a few other things your patients need and try to manage those. You might do just HIV. PEP and PrEP would be a great case for office dispense because you want to really make sure those patients get started and they get started now, especially in a post-exposure environment. Your patient might be very scared. There's some reassurance to getting the medication started right now. And we want to make sure that patient gets started and is adherent to the therapy on an ongoing basis. I think that's really important if we're looking at just HIV therapy.
I really appreciate you bringing up PrEP and medications for those living with HIV. I work very closely with the HIV STI program at OPCA and actually wrote a piece about PrEP. In that post, I noted that the U.S. Food and Drug Administration approved the first PrEP option that could be administered twice a year in June 2025. So what you just explained about scope, specifically HIV therapy, it really resonated with me how office dispensing can address the issue of access, especially in rural and frontier areas.
I think there's a really strong use case there where it really, really makes sense. Pharmacy has an important role and office dispensing shouldn't be trying to take over everything. But in the use cases where it really serves an important need, I think that's the ultimate best case for it. And depending on the level of sophistication, what your patients need and the staff that you might have available to work on it, it's just one like really clean example that I think people tend to understand. And then it can be like, well, what else? Like, why not diabetes? Why not hepatitis C? What does your community need? You brought up something interesting. So when we look at PrEP, we've got oral meds, but then you've got the long acting, so you've got Apretude, Cabenuva, and there's a couple of them. And so these are administered in clinic typically. And so those would ordinarily be billed on a medical claim. You might think that, well, office dispense doesn't have a role here if it's something billed on a medical claim. But here's where these worlds kind of collide, is increasingly we have patients whose benefit design for medical loss ratio reasons and other things in the insurance world, where their benefit design is trying to take expensive drugs, specialty drugs, and move them to the pharmacy benefit. And so in some cases, the patient's medical benefit won't cover it. They have to get it from a pharmacy, bring it into the clinic, or the pharmacy has to ship it to the clinic, or the specialty pharmacy takes care of it and ships it in, whatever. If the payer will let you bill it on a pharmacy claim, then if the clinic has the office dispense software available to do that, now the clinic's got the option to bill the pharmacy benefit. So now we may avoid a pharmacy white bagging scenario that can be confusing and wasteful and can cause delays. Now the clinic can manage that all internal. And so sometimes these drugs that you think of as office administered drugs, the RxFusion platform opens up some convenience for the clinic.
I really do appreciate you sitting down with me.
Absolutely. Yeah, this is fun.
Before we close, I want to come back to something Josh said that really struck me. At the end of the day, this is about optimizing the way life-saving medications are delivered to those who need them most. The federal 340B drug pricing program was built on exactly that promise. And for 34 years, it has been a lifeline for health centers and the patients they serve. But that promise is now under threat. Pharmaceutical manufacturers are pushing to replace the current model with a rebate system, and the consequences are severe. Instead of upfront savings, qualifying providers would be forced to cover medication costs out of pocket and wait to be reimbursed. For health centers already operating on razor-thin margins, that delay isn't just an inconvenience. It's a crisis. It undermines their ability to provide affordable care, and it puts patients' access to treatment directly at risk. These are real challenges, and they don't get solved by staying quiet. That's exactly why conversations like this one matter. In our next episode, my colleague, Marty Carty, joins me to unpack everything we heard today, the history of 340B, where the program is headed, and what's truly at stake for covered entities, especially health centers, if these changes go through. If you believe these conversations need to happen, help us grow our community. Subscribe so you never miss what's next, and also leave us a review. That helps more primary care providers and health center advocates find the show. Today's conversation was produced and edited by Dani Gehrke, and fact-checked by Priya Thoran, who also helped with research. I'm Dani Gehrke with the Oregon Primary Care Association, and thank you for listening.